Right. Welcome back, everybody. I'm very excited for another presentation and talk series with everybody. I am not sure if Mira will be joining us today, so on her behalf, I'm going to give our reminder that we are starting off our brand new Radcliffe study. You can find more information and sign up to see if you meet eligibility at everythingals.org/RAD, R-A-D as in dog, speaking with the four-legged friends, study, all one word, RAD study. So we would love to have you aboard. It's a very exciting multidisciplinary study. And that's our update there on everything ALS is in. Unless Indu, you've got one you've want to announce before we kick off?
Sorry, I was on mute here. No, you did it well. So I just put it on the chat there, everythingals.org/research. Thank you, everyone.
Perfect. All right, let's give a little introduction to our guest speaker today, Dr. Kate Brizzi. She is an assistant professor of neurology at Massachusetts General Hospital in Boston, Massachusetts, which I always have a difficulty pronouncing. She completed a neurology residency at the, once again, Massachusetts General Brigham, formerly Partners Neurology Program, and was a chief resident. Following completion of residency, Dr. Brizzi completed fellowships in advanced general and autoimmune neurology and palliative care. Dr. Brizzi is a board-certified neurologist and palliative care clinician and works as an embedded clinician in the Healy Center ALS Clinic at Massachusetts General Hospital. She focuses on strategies for improving the quality of life for people with ALS and their caregivers. Dr. Brizzi is also involved in the education of medical students, residents, and peers around neuro-palliative care topics. To say she is qualified would be an understatement, and we are very happy to have her today. Dr. Brizzi, welcome.
Thank you so much, and it's really a pleasure to be here today. I'm going to go ahead and just share my screen. 1 second.
Very nice.
All right. And let me just fix one thing here. Terrific. Well, thank you again for the kind introduction. I work at Mass General Hospital in the Department of Neurology and the Department of Palliative Care, and have a role specifically in the ALS program here, working on providing neuropalliative care and supportive neurology services. And I'll talk a little bit more about that as we go on today. I would encourage certainly any questions as we go on today. Please feel free. I would love to hear from you and answer any questions I can.
So we will have a separate Q&A once your presentation is completed. We're collecting the questions now, so we'll get to that at the end.
That sounds fantastic. So the things that I'm hoping to talk about today is, first off, just defining palliative care and explaining how it can benefit people with ALS and caregivers of people with ALS. I'll be talking a little bit about what actually takes place and trying to sort of demystify what happens in a palliative care assessment and visit. And then importantly, I'll be talking about the difference between palliative care and hospice, because this often causes some confusion, both for actually providers as well as for people that I see in clinic. So I'll start off today with a definition that I like. This comes from the Center to Advance Palliative Care. This is a definition of palliative care, and it states that palliative care is specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. And part of the reason I really like this definition is that it focuses on, both the person that's dealing with ALS and their caregivers as well. And I think that is a really important aspect of palliative care. Additionally, I like this definition because it really talks a little bit about how palliative care is focused on really relieving symptoms that may be distressing and actually helping someone to cope with having a serious illness. In a nutshell, palliative care really focuses on how to live well with a serious disease. Palliative care is at its core a very collaborative field. I have the benefit of working alongside some really amazing other team members, including nurses, nurse practitioners, physical therapists, speech and language therapists, my other neurologists. It's a very collaborative team and a very interprofessional team, and that's at the core of palliative care. In fact, actually, even in our training, when we do palliative care fellowship, the fellowship training is actually alongside social work fellows. I had nurse practitioner fellows, nurse fellows, even a pharmacy fellow. And so there's really, even at the core of palliative care, is this this approach that recognizes the importance of really interprofessional care. Palliative care is an approach to care, a philosophy of care that, you know, can be really done alongside other treatments that someone might be receiving. So for example, you know, it can be done alongside other disease modifying therapies, or while someone is getting research, they can also be receiving palliative care services. As I mentioned before, you know, palliative care importantly focuses on both the person living with ALS as well as their caregivers as well. And really the goal is to alleviate suffering. I emphasize that palliative care is really appropriate at any stage of disease. I meet some people very early on, some people who have just been diagnosed. I meet others further along. And it really just depends on a little bit about when the neurologist feels like it might be appropriate to get me involved, or when they think I could be of added benefit. And so that really varies, you know, from person to person, but importantly, palliative care is really appropriate at any stage of a disease. And as I mentioned before, it emphasizes a team approach. So what are the benefits of palliative care? Actually, we have a good amount of research in the oncology world that actually has looked at the benefits of palliative care. We are still hoping for sort of more research in ALS specifically. And I think I was talking to someone very recently about how, you know, palliative care sort of originated out of oncology, but in the last 10 years or so, there's really been a recognition that this approach of really focusing on how to manage symptoms well, how to really focus on helping people live well, is absolutely applicable to neurologic conditions. There's something that just came up in the middle of the screen. Does anyone else see that circle in the middle of the screen?
Yeah, I sure do.
I don't know where that came from.
Somebody, please, whoever put that up, can you take it down? I saw a little scribble before and you took that away. So could you take this away, please?
Trying to see what I can do on my end. I have no idea how that got up there.
No worries.
Do you think we can reshare?
I can
was
start
just-
do that. Yeah, I'll stop the share and I'll just restart it there.
Perfect.
Thank you.
Let's see here. All right, we're all set. So as I was just mentioning, we actually have quite a bit of research actually in the oncology field, but in neurology fields, really palliative care has been an approach that's really only been recognized, I would say probably in the last 10 years or so, although it's gained a lot of traction in that time period. However, some of the studies that have looked at implementing a palliative care approach in oncology in fields like heart failure have noticed a number of different benefits. Importantly, they've noticed that palliative care is associated with significant improvements in how people rate their quality of life and their symptom burden. Importantly, it also has been associated with increased caregiver satisfaction and improvements in mood for both the person dealing with the condition as well as caregivers as well. And then I think, you know, really exciting, you know, studies in cancer have actually shown longer survival for people who have had access to palliative care. And a lot of this comes from work that's been done by Jennifer Temmel and her group. They published a very important piece in the New England Journal of Medicine that looked at a randomized control trial where they implemented early access to palliative care for people who had metastatic lung cancer, and compared that to a group of people with metastatic lung cancer that did not have that early access to palliative care, and showed that the people who had access to those services and regular visits with palliative care had longer survival. We're still trying to learn a little bit about kind of why that happens. And one of my mentors, Vicki Jackson, she calls it the secret sauce. Trying to understand kind of what is in that, what it is that in palliative care that kind of led to those improved outcomes. But I think it's really exciting, and I'm certainly hopeful that we will do certain similar studies, actually in ALS, and see what are some of the benefits of palliative care for people with ALS as well. I would argue that there's certainly, benefits for people with ALS and for caregivers with ALS. This is some work that was done recently and actually published looking at people with Parkinson's disease and their caregivers who had access to a palliative care intervention. This work was done by Brizzi and his group at University of Rochester. And what they did was they had a comprehensive intervention for people with Parkinson's, and those who did have that palliative care intervention reported improved quality of life even out 12 months from the time of intervention. And similarly, their caregivers reported improvements in caregiver strain and other markers at also 12 months out. And these were significant results. So again, I think very exciting, especially seeing some of this palliative care research coming into neurology fields. And again, thinking a little bit about how we might also explore this in ALS as well. One question that I often receive is, what is the difference between palliative care and hospice? And this is a really great question. I get this question both from providers and other physicians, as well as, people who are living with ALS as well. So palliative care and hospice both are approaches and philosophies to care that really focus on the relief of symptoms. And again, those can be both physical or emotional symptoms. I would say both palliative care and hospice can be delivered in multiple different environments, for example, in the home or at a facility. But the difference is that, palliative care is really applicable at any stage of the disease. As I mentioned earlier, I will meet some people very early on, maybe even shortly after they've been diagnosed, and really can be delivered alongside other disease modifying therapies. People can be receiving Radicava and Riluzole and Relyvrio, and be receiving palliative care at the same time. With palliative care, there's typically intermittent visits. So for example, I tend to meet with people about every 4 to 6 weeks or so. And palliative care is typically paid for by insurance. Hospice has a similar, again, goal of focusing on relief of symptoms, but really in hospice, there is more sort of frequent visits by nurses or physicians. And really the focus is on helping someone to live well at home and avoiding further hospitalizations. Hospice is typically utilized for individuals that have more advanced disease, although I will say that there's actually a lot of variability about that. And it really depends on when people could benefit from those additional services. Typically, hospice is paid for by Medicare or Medicaid, but it can also be paid for by other insurances as well. And so I would say those are sort of the main differences between palliative care and hospice. I sort of think of palliative care as the larger umbrella, and hospice is sort of a subset of sort of more intensive care services for individuals who may benefit from that. So what actually happens in a palliative care clinic visit? I want to sort of just demystify a little bit about what actually happens during a visit. And during the visit, how I usually start my visits actually is really in focusing on getting to know the person with ALS as a person. I think, I will often say at the beginning of my visits that, I can read about the ALS in the chart. What I can't read about is about the things that makes that person tick, knowing about kind of who their support system is, knowing about some of the things that are important to them in their day-to-day life. And so usually I actually will focus on that as at my initial visits, and really trying to get to know that person well and getting to know the important people in their life. I will say that that is actually, one of the privileges I think in the work that I do, is that I really have the opportunity to really get to know both the person with ALS and their caregivers, to get to know them well, and getting to know them as a person. I think, another aspect of what we will do during our clinic visits is really focusing on how I can help with physical or emotional symptoms. This is collaborative together with the person's primary neurologist. But I may focus in more depth on certain symptoms that maybe don't come up as often in the clinic visit. For example, focusing on some of the non-motor symptoms that might come up, focusing on things like how do we manage cases of maybe more complex sort of excess saliva? How do we focus on the treatment of physical symptoms, such as difficulty with constipation or muscle spasms? Thinking a little bit about how we might help with some of those physical symptoms. And then importantly, thinking about how we can help with managing emotional symptoms as well. Thinking about how we might manage anxiety, managing changes in mood, and helping to think about how we might cope with some of the changes that occur. So those are some of the things that I focus on in my clinic visits. I think importantly, another aspect of palliative care visits is focusing on goals and hopes for the future and thinking about how we can help and how we can align. This can sometimes feel a little bit daunting to sort of think a little bit about talking about the future, but importantly, this is something that we will gradually do over time and something that we only do when people feel comfortable with talking about some of their hopes and values and goals. And that brings me to sort of the third point here, which is sort of discussing how someone likes to receive information. One of the important aspects of visits with a palliative care provider is learning a little bit about how people like to receive information. Are they somebody who prefers sort of the bigger picture? Are they someone who does like to get details? Are they someone who, kind of wants to really focus on kind of the day-to-day and focusing on, thinking a little bit about things that might be more relevant for right now versus thinking about things down the road? That's an important aspect of the palliative care clinic visit. I have this picture of a box here just to remind me that, I will often talk about in my visits with people that I see about this concept of a box and the idea that we try to compartmentalize some of those things about the future that may be difficult to talk about. But from time to time, we may bring those things out and explore them together in a way that feels safe, in a way that feels helpful. And so you might be listening to this and thinking, hey, I think I'm getting, some of these aspects of palliative care from my primary neurologist. And you are absolutely right. Everyone on your ALS team is providing aspects of palliative care because they are all focused on helping you to live well and all focused on thinking about how they can help you to feel better. So everyone in that respect, everyone on your ALS team is really providing aspects of palliative care. What a palliative care specialist can provide is sort of a dedicated focus to some of these issues, to a dedicated focus to some of the symptom management, and providing sort of a safe space for planning for the future, again, as much or as little as someone would feel comfortable talking about. Not everyone has access to a palliative care specialist, as I mentioned before, especially when it comes to neurology and palliative care. This is something that's really only been kind of growing over maybe I'd say the last 10 years or so. And so palliative care specialists with expertise in ALS are not located everywhere. However, there are actually many ways to access a palliative care specialist, and a lot of that can actually be through the community. So oftentimes we will actually partner with palliative care specialists in the community, and some of those may be under like a hospice umbrella. So for example, a hospice organization may have what's called a palliative care arm to it, where they provide palliative care services as a sort of like a subset of what they provide. And so people can still have access to a palliative care nurse or nurse practitioner or physician through that approach, even if they don't have access to a palliative care specialist in their ALS clinic or in with their neurologist that they are seeing. So there's lots of ways of accessing a palliative care specialist. I will also say that many of the neurologists that we see have also done some additional training, even if it's not a specific palliative care fellowship. Many neurologists will actually seek out some additional training into this skill set. And so they are also able to deliver some of the more advanced palliative care skills. One thing I want to emphasize is that, during the palliative care visit, the person with ALS is really in the driver's seat. And so, how much is discussed and what is discussed is really a collaborative discussion between the provider and the person with ALS. I think that's really important. And that gets back to, again, that sort of box analogy I was mentioning earlier, and the idea that, the opening and the closing of the box is something that the person with ALS has complete control over during the visit. I think the other aspect that is really important to note is that, the person with ALS who is the focus of the visit is also, the one who is going to be in the driver's seat for saying who needs to be present for important conversations. So sometimes, maybe I will meet with the person with ALS, but then other times they'll say, hey, I think it might be important to have my healthcare proxy or have, my brother or sister, present for the conversation. And, again, that is really, something that we try to focus on, is sort of thinking about who are the important people who should be present for these conversations. And then I think how information is presented, understanding what type of information is important to that person and how they'd like to receive it. I know it can, as I mentioned before, that, I've heard from some people that, the idea of sort of thinking and talking about the future with a provider can sometimes feel a little scary. And I think that's a very normal response and a very normal feeling. The one thing I'd like to emphasize, though, is that actually research has shown that conversations about the future can actually help lower anxiety and depression. This is some really important work that was done actually at our sister hospital. And, while this work, again, was done within the oncology population, I will say that my experience working in the ALS clinic is that, I think that this very much holds true for for people with ALS as well. What they did was they actually had a control group and they had an intervention group. And in the intervention group, they had an important conversation, a conversation about that person's goals and values, conversations about their hopes and worries for the future. And then they looked at, ratings of anxiety and depression, both before and after the conversation. And I thought it was really interesting that the research showed this sort of drop off where anxiety actually improved significantly and depression improved as well, after that conversation happened. And again, I think this is very much what we see in the clinic as well. I think that, certainly this could hold true for healthcare proxies or for caregivers as well, in being part of these conversations. Another aspect that palliative care can provide is, providing a space for thinking about decisions related to medical care. I will often meet in the clinic to talk in more depth with people about, how their disease might affect their functioning and changes to their living situation, or maybe having conversations about possible medical decisions in the future. For example, maybe someone will have questions about thinking about things like a feeding tube, for example, and whether or not that might be aligned with their goals. And so the palliative care visit can be a space for exploring that and for talking about that in more detail. It can also be a space for help with thinking about advance directives. And if you aren't familiar with the term advance directives, these are documents which help to really try to explain and lay out what a person's wishes would be if they were in a situation where they couldn't speak for themselves. So many of you have probably heard of things like a power of attorney or a living will. Those are all different types of advance directives. I'm a big believer that I think everyone should have advance directives. It's certainly something that I've talked with my own family members about. I think advance directives are important for everyone. And very importantly, I think everyone should have a healthcare proxy, kind of have designated a person that is their decision maker if they're in a situation that they wouldn't be able to speak for themselves. I think, though, one thing I will say is that it's really important, if you are going to have a healthcare proxy, you want to make sure that you set that person up for success. And so that means making sure you're having conversations with that person about what's important to you, and so that they can accurately represent your goals and values. During our clinic visits, we can complete certain types of advance directives. I have an example here of what's called a POST form. And these vary from state to state. but the pALS is actually the one that is most commonly used in the greatest number of states across the United States. This may potentially differ outside of the US, and I apologize that I don't have a good sense of in other countries about how this may actually play out. But here in the pALS form, this is an opportunity to again to talk about someone's goals and values in the setting of more invasive treatments. And again, this would be a form that you would complete together with a medical professional during a clinic visit in a collaborative discussion about one's goals. You know, in thinking a little bit about kind of, you know, why we make space for these conversations and why palliative care is so important and why these conversations together, you know, with a provider are so essential. I think that, you know, these conversations about one's goals and values really help to improve communication between the person dealing with ALS and the provider. I think that in and of itself really can help the team make recommendations. So many times, you know, I will have visits with someone and, you know, they're saying that, you know, they're in a place where they're having a hard time making a decision about some type of a medical intervention. And so what we will do is we'll take a step back and say, you know, let's take a step back from the medical decision and let's talk a little bit about you and your health priorities and your health goals. And by understanding that, I, as the provider, or the same would go for the person's neurologist, you know, or other, you know, trusted practitioner, you know, are then able to help make recommendations that align with that person's goals and values. I think these conversations are also very important because they help to reduce stress for loved ones. There's been a number of studies that have looked and found that, you know, when these conversations happen, they do reduce stress for caregivers or healthcare proxies if they do end up being in a situation where they have to make decisions for others. And then I think importantly, this just provides a space for planning ahead. I also think that these are really opportunities to think about how we help someone reach their goals. I had a conversation with someone not too long ago for whom travel was super important to them. And they were worried about doing that as their disease changed. And so it was really an opportunity for us to talk together and say, like, let's see how to make that goal happen. You know, this is something that's really important to you. You know, this is something that I have seen other people do. Like, let's think about how we can make that goal happen for you and how we can help bring the important people into the fold for that. And so, you know, that's another just really important aspect of these conversations. Sometimes it can feel hard to kind of broach these important conversations together with the provider there in the moment, and that's okay. What I will often say is that if that does feel like that's the case, sometimes it can feel easier to have these conversations, you know, with a family member or with someone who is a trusted friend. In those situations, there are actually some conversation guides that are available online that can help to sort of guide that conversation and at least provide some foundation for it. There's a number of different ones here. I'll just sort of highlight the one from Ariadne Labs, you know, which really focuses again on that 3,000-foot view, not focusing on individual medical decisions, but really providing an opportunity for talking a little bit about what matters to that person, what their goals are, what their values are, and sort of thinking a little bit about that in more detail. The Conversation Project and 5 Wishes are two other, you know, resources, and there are a number of other resources that, you know, this is by no means a comprehensive list that are out there that can help for guiding those types of conversations. So I'll pose this question here, you know, as we come toward the end of this part of the discussion. You know, so when is actually the right time for palliative care? I would argue anytime. And hopefully that's come across in our talk today. You know, I think the palliative care approach is really something that can be applicable at any time in the course of someone who is dealing with ALS. It could be early on in the disease, it could be later. It just really depends on what works for that person and when they feel like you know, having that sort of focus on thinking about how to manage their symptoms, thinking about talking about some of their goals and values feels right to them. So just to summarize, palliative care works alongside other ALS treatments to help people live well. Palliative care is applicable at any time during a disease, even from the time of diagnosis. And hopefully, one of the goals really with palliative care can be to provide a space to help people plan for the future. So I'm going to actually stop my screen share right there, and I will be back so we can all see each other.
Perfect. Thank you so much. I've also wondered myself what the difference was between palliative care and hospice. So that was very nice to see that clarified. Thank you so much.
Sure.
Myself and Grace, our other ALS fellow, are going to rotate asking questions. Our first one kicking off is, if a pALS is having a bad time dealing with their condition, what services does palliative care provide commonly? I think would be a good way to approach that one. And does palliative care specifically include mental health support and services for grief, et cetera?
That's a really excellent question. What I was going to say is that, we actually focus often in our visits on thinking about how one copes, with ALS. And that's part of one of the reasons that I actually try to meet with people frequently. I know that many times it's hard. Your neurologist may only be able to meet every, 3 months or so. And so I always hope to provide that additional continuity where I have a chance to really have a focused kind of visit where we can focus and think about different coping strategies, thinking about opportunities for, other opportunities and for kind of joy and cultivation of gratitude, thinking about ways that we can together, think about where some of the stressors are coming from and how we might approach them. And so that is it's actually a big component of a palliative care visit. In terms of dedicated sort of mental health, I think it said services, I think was the word that you had used. What I would say is it varies a lot from clinic to clinic. So there are many sort of palliative care departments that actually have dedicated social workers that are able to provide sort of longitudinal therapy. Others may not have access to that. So it really does actually, unfortunately, vary quite a bit, from clinic to clinic in terms of kind of what's able to be provided.
Awesome. Thank you so much for that answer. Our next question is, do you think ketamine therapy could be beneficial for palliative care for ALS?
It's a really great question as well. There's actually been some pretty encouraging data in terms of ketamine for in the psychiatry space and its use for kind of depression and anxiety. I am not familiar, with work specifically for people with ALS. But I know there is some ongoing discussion about thinking about using some of these therapies, including ketamine, as one approach in thinking about kind of managing a certain symptoms, specifically thinking about kind of emotional symptoms related to the disease.
I know you touched upon this as well, and ALS has a tendency to be a very highly individual disease in terms of how onset unfolds. However, is there in your expertise somewhat of a schedule of things that palliative care does in terms for early to mid to late stage for ALS?
That's a good question. One of the things that we talk about actually usually in one of my earlier visits with folks, regardless of when I meet them, is talking a little bit about this concept of what I call the disease roadmap, and acknowledging the fact that everybody's experience with the disease is different. But that being said, that there are different sort of signposts that we can look for and that we can help to identify to help us understand better how the disease is changing. And so what I will usually try to do with that person is try to understand a little bit about some of those signposts that they've seen or not seen, and use that to help kind of gauge then kind of which symptoms we may focus on, and thinking a little bit about how we might think about the further steps on that roadmap. I hope that answers that question.
Yes, thank you. And kind of relating to our next question here, just the very first step, what would you say the best way to approach a family member with ALS about palliative care? How would you approach them for just starting off?
I think, I think, again, just because sometimes there can be a little bit of confusion about what palliative care is, I think that part is really important. I think I would often say to someone, I've heard that there are some, additional services that really can be beneficial to people who are living with a serious illness. And some of those services, can really help focus on how to help someone live well. One of those services is palliative care, and which has been shown to have a lot of benefit for people who are dealing with a serious illness. Is that something that you'd be open to or open to learning more about? So that's just one suggestion. I think it really depends again on the person. But I think helping to provide a context, for it and a definition a little bit about what it is, because people may not be familiar with the term. There's actually a lot of argument within the palliative care community about changing the name of palliative care. In fact, some people have, argued for switching and calling it supportive care. But there's no consensus on this, and people go back and forth and debate these things. So.
I think the definition's a great jumping off point to have that conversation. Specifically, though, is palliative care available in nursing homes?
It is, yes. Usually the easiest way to access that is actually normally how that works is that an outside agency, like for example, a hospice will have, as I was mentioning, like sort of the hospice that has a palliative care arm. They would then be able to send somebody that would come in, like, for example, like every month to help to kind of check in on and provide those services. That's usually the easiest way of approaching that, because the nursing home itself may not necessarily have palliative care. Some do, but not all. And if they don't, the way to achieve that, it would be kind of going through sort of an outside hospice that has a palliative care arm.
Great, thank you. So our next question, you mentioned that palliative care is covered by insurance, but this person wanted to know if it's going to be covered by Medicare. Would that also cover palliative?
Yes, it does as well. Mm-hmm.
We like to hear that.
Yes.
Anytime we can hear that, we give a cheer for that.
That's right.
This one was also interesting, I thought. So would a patient come to your office, or would you visit the patient at home if they were interested in palliative care?
Oh, I'm so glad you asked that. I actually meant to mention that in the context of the talk. So this varies a little bit from clinic to clinic. The way our clinic works is that I actually do a lot of virtual visits, and that's partially actually to just make it easy. A lot of the folks that I'm seeing live pretty far away. I see actually some people all the way up in Maine, some people down, and I'm in Massachusetts. Some people are in Rhode Island, people are far away. So I actually do a lot of virtual visits, and I also find that that's nice because people are in kind of the comfort of their own home. They don't have to get ready to travel for a long day to clinic. I do, though, I also offer the opportunity to see people in person in clinic if they want to see me on the day that they come in for their visit with the ALS multidisciplinary clinic. And then there are certain home visits that are available as well. That depends again on the provider and like what their geographic access is. But I would say that most of the palliative care specialists that at least that I'm aware of are doing a combination of in-person and virtual visits. I think virtual visits, it's one of the blessings that's come out of, I think, the pandemic is just the greater access to care from home, which I think has been a big change for all of us. But I think, one thing that's been a real positive.
Absolutely. Care from home is definitely a big step forward, I think.
For sure.
So our next question then is, how would you say palliative care differs from like an ALS clinic where they also see doctors and therapists and psychiatrists and nutritionists, etc.?
I think that it doesn't have to necessarily. And, in my situation, I'm sort of an embedded provider within the ALS clinic. So I'm part of that whole team. And focusing more intensively on thinking about symptom management and thinking about, how we can have conversations about, thinking about the future. I would say that in situations where there's not a provider that's in that clinic, in those situations, again, I think it's about providing more of the space for those conversations. My experience, I love our multidisciplinary clinic. My experience has been though that those days are long. It's a 3-hour marathon of like visits, seeing everybody, the physical therapist, the speech and language therapist, and everybody's awesome. But it's also hard to really have a sit down, like important conversation about, maybe thinking about some of those things on that roadmap. And so I look at palliative care as having a space for doing that and having an opportunity to really have a dedicated conversation about those goals, or focus on intensively on symptoms. So for example, in our clinic, if the ALS physician is having difficulty with managing someone's pain, they will often come to me and say, hey, can you weigh in, and provide your expertise in thinking about kind of what would be the next level steps of how we might manage some of these symptoms. And that's often how, at least the relationship that I have with the providers that I work with.
I love that. This one's a simple question, but important. Outside of ALS clinics, how does palliative care reach the PALS community?
It's a really great question. I would say that there's a couple of different resources. One is that, as I mentioned before, there is certainly the like community-based, palliative care via, which can be through VNA, it can be through, hospice agencies. The other thing I was going to mention is that, as I alluded to before, the idea of, incorporating palliative care for people who have neurologic conditions is relatively new, actually within the last like sort of 10 years or so. And so we are a young organization, but there's actually the International Neuro Palliative Care Society, which I encourage people to check out. And we actually have a space in there also for people who are dealing with neurologic conditions and for their caregivers. We're actually looking for people to have a voice at the table, as well, in thinking a little bit about how we do better in terms of getting palliative care services to a greater community. So there's certainly opportunities. If people are interested, you can also reach out to me, and I'm happy to try to connect you.
So that's pretty much actually exactly the next question that was asked, and maybe you can expand even a little bit more on it. But so this palliative care for ALS is, you said, relatively new for neurological disorders. Do you know of any other like active research and studies working with PALS in terms of palliative care? I know you mentioned that one.
There are some studies that are kind of like up and coming. I don't know. A lot of them are based at particular institutions rather than being sort of multi-site. There are, I think that, International Neuropalliative Care Society is a good place to start, just because they have, a good sense of which studies are kind of up and coming. I had alluded a little bit before to like Brizzi Kluger, who he's actually in charge of the International Neuropalliative Care Society and does a lot of research in palliative care and thinking about how palliative care might be implemented outside of oncology, where it's been, sort of traditionally sort of thought about. And so, I will say they're up and coming, but it's a little bit institution dependent and geographically dependent at this point.
Sticking on that same topic, can PALS participating in clinical trials be involved in palliative care? This individual stated that they know that hospice rules out trial participation. So is it the same for palliative care?
Oh, you can definitely. And actually, I will say that not all, and just to kind of piggyback on that. So with palliative care, you absolutely can be involved in clinical trials, 100%. I will also say actually that it depends on the hospice. So some hospices actually also allow, trial participation. And in fact, there's actually even I know of some hospices that are actually are part of a trial, or specifically part of a trial. So for example, someone had asked a question earlier about ketamine. And while I'm not familiar with a specific study for ketamine, we do have, for example, a hospice that's running a study on psilocybin, and looking at that for treatment, for people who are enrolled in hospice. So there are actually studies even within hospice, that are available too. It really just kind of depends on the hospice.
And real quick, because it came in, do you know what the link to the International Palliative Care Organization is?
Yeah, I can also send that out. I don't know if there's I can send it out here. Let's see here. think it's inpcs.org. I'm just double checking here. Yes. It is inpcs.org. I'll actually just put it right here in the chat.
Perfect. There it is.
Okay, so then our next question, can one work with a caregiver of ALS even when the PALS is not directly involved?
Do you mean like work with, like, for example, like seeing a palliative care specialist?
I believe that's what it meant.
Yeah, it gets a little tricky in that, so like, you know, technically insurance, so palliative care is technically through insurance, which means that that the person for whom the visit's there technically it should be there. However, what my personal practice is that, you know, I will have an initial visit, you know, with the person with ALS, but then I may offer to do a separate phone call. If the caregiver wants to have a conversation, I may offer to do a phone call or a separate visit with them after that, sort of outside of the clinic space, provided that I have the consent of the PALS in terms of, you know, having that conversation.
Excellent. And this is going to be our last question for the Q&A. Are there any steps taken to get palliative care into the Veterans Health Administration specifically? And if so, what would be the process for that?
So actually, the many VAs actually do have a pretty robust palliative care program. I will say, unfortunately, like so many things, it varies so much geographically. You know, but I do know that the VA health system does have a pretty robust palliative care department. I just will say that it varies probably from VA to VA in terms of whether or not that's available. That's the best of my knowledge, unfortunately, on that topic.
Excellent. Gives us a jumping off point. I want to thank Dr. Brizzi for presenting and educating us on palliative care in general. The next portion of our meeting is our open forum where we stop the recording. Dr. Brizzi, you are more than welcome to join, but we understand you're very, very busy. So if you have to dip out, we understand that as well.
I really appreciate the opportunity to be here tonight. So thank you so much.
Oh, thank you for joining us, truly. I'm going to turn it over now to McFinn.
Well, everybody, are we getting really practical now? It's, you know, we have a lot of scientists and a lot of researchers and doctors and all kinds of folks. And tonight I felt like we were down home. And I think that basically every day is the most important day of your life, not next week or last week. And I think being cared for and knowing how to accept care is a wonderful thing in your life to keep you at ease, because a lot of us think that we just want to take care of it ourselves. Well, once we give in to the greater population that really loves us, we find that things get a little bit lighter. We get a little bit more grounded.